Hello, Dr. Karina Iregui here from Soundbridge Dental Sleep Apnea Therapy, or Sleep Apnea Gig Harbor. And I'm here today to discuss with you as a dental professional how you screen your patients for obstructive sleep apnea. Back on October 23rd of 2017, the American Dental Association mandated that dentists screen patients for sleep disordered breathing. Screening is great, but you've got to know what you're looking for. You as a dentist are in the prime position of looking into the patient's oral airway, where the symptoms of obstructive sleep apnea are the most clear. You also can tie that into how they look physically, what their systemic health consists of, and put together a whole picture of whether you would suspect a patient of having obstructive sleep apnea. You're actually probably in a better position than their primary care physician or any other health provider that they see on a regular basis, because those providers aren't looking down the airway and don't have that clear view that you do while you're in there doing a cleaning, doing a filling, doing sealants. So let's review, what exactly do you look for when you are screening a patient for sleep apnea? And it doesn't even have to be an intentional screening. It's something that just happens while you're seeing your patients on their recall, or like I said, for any restorative work. So let's talk about what a patient may indicate on their health history that would sort of tip you off as to whether you need to delve deeper into the possibility that they may have a sleep disordered breathing. A list of several of the health side effects of sleep apnea are heart disease and high blood pressure, diabetes, liver disease, acid reflux, obesity, stroke, diabetes, and mood disorders such as depression. Particularly if you have a patient who's on multiple medications to control their high blood pressure, or multiple medications to control their diabetes, or again, multiple medications to control depression and mood disorders. These are all signs that a person may not be sleeping well, and consequently, they're having systemic effects of decreased breathing while they sleep. The other sort of tip-off, and this is a big one, is metabolic syndrome. So what does metabolic syndrome consist of? There are 5 specific symptoms that fall within metabolic syndrome: high cholesterol, high triglycerides, above normal blood sugar, obesity, and above normal blood pressure. If a patient has any 3 or more of those 5 symptoms, they are diagnosed with metabolic syndrome. So these are all things, again, that are probably already on your health history, that when you review their health history, you should think to yourself, I should screen this patient or delve deeper into their quality of sleep. So now let's talk about some specific screening questions that could be included in your health history that would be aimed not towards systemic health necessarily, but toward quality of sleep. There are 2 screening tools that you could use. One is called the Epworth Sleep Questionnaire. It is not geared specifically towards obstructive sleep apnea, but it is a telltale sort of questionnaire that will give you an idea of whether your patient is excessively tired on a day-to-day basis. The other screening tool that is specific for sleep apnea is the Stop Bang Questionnaire. And again, either or both could be included in your health history. We will have an example of those at the end of this segment of the video. So now, specific questions that you may want to ask either on your health history, or if you're done your oral exam and you notice signs of sleep disordered breathing by looking into the patient's oral airway. Things you'd want to include are: do you snore? Do you suffer from excessive daytime sleepiness? Do you experience drowsy driving or falling asleep at the wheel when you're driving? There are, the latest statistics I heard, about 27% of fatal accidents are caused by people falling asleep at the wheel, and it is equivalent to driving while under the influence of alcohol. So that's an important question. Do you wake up multiple times a night to use the bathroom? Does your bed partner nudge you consistently throughout the night? One thing that I feel is very important is to stress to your patients that snoring is not normal. Snoring doesn't necessarily indicate that there is obstructive sleep apnea, but it is bothersome to sleep. So if a person snores but doesn't have narrowing of the airway, they still could be hindering their quality of sleep. Snoring, on the other hand, is always going to occur in people who do have narrowing or complete obstruction of the airway for the most part. So that is a critical piece of information that is important for you to obtain from your patients. Some other questions or indications: if a patient says, you know, my mouth is really dry when I wake up in the morning, and you don't necessarily notice that they're on medications that should be causing that. Do they dream about drowning or choking? I've had a lot of patients that have told me that since they started oral appliance therapy or they've treated their obstructive sleep apnea, they no longer dream that they're drowning, or they don't wake up choking or gasping for air. Any of these that your patient would answer yes to is a clear sign that you should be referring them to their physician to be tested for obstructive sleep apnea. So let me introduce you to Victoria. Victoria was in for her dental cleaning, and we're now going to do her biannual exam. She had indicated on her health history, on her update, that she wasn't sleeping well. She had been told that she does snore, and her Epworth Sleep Questionnaire was at a higher level of a 10. In her health changes, she's recently been diagnosed with some high cholesterol that she's not currently taking medication for. So again, a tip off to me that she might be suffering from sleep disordered breathing, so I should pay attention to any signs in her oral cavity that she is having problems breathing while she sleeps. So the first thing I'm going to look at, and just take a general look, her neck circumference. Female's neck circumference, if you look at it and it looks that it's 15 inches or greater, and for men, 17 inches or greater, that is the type of patient that you want to tip off, or that you want to think about, I need to assess this person for sleep disordered breathing. Of course, it's not the only thing. I have a lot of patients who are, you know, athletes who are trim and they still have sleep apnea because of some of the things that we're going to be looking at further into the oral airway. So the first thing I'm going to look at is I'm going to have her open. Victoria, go ahead and open for me. And I'm going to look at her tongue. Can you notice that it is scalloped on the lateral borders? This is an indication that her tongue is large for her oral cavity. And go ahead and stick your tongue out. And it is also coated, which may be an indication that she is breathing through her mouth at night in order to get air. And go ahead and close, and then open again for me. Now let's take a look at her tongue level. So I'm going to have her just open. Do you see how her tongue level is significantly above the occlusal plane of her teeth? This is going to be a tongue level 3. Kind of flatten your tongue down for me a little bit. There you go. And then go ahead and stick your tongue out at me. We also look at Malampati. I cannot see back into her oral cavity or her oral airway, so Malampati of 4. I had to go all the way back to my dental school to remember about Malampati because it had been forever. We will have a refresher photo at the end of this segment. Again, though, these are all indications that her tongue is large for her oral cavity, and consequently, when sleeping and when she relaxes, that tongue falls back and has a greater chance of obstructing her airway. All right, now let's take a look in the back of her throat. So the first thing we're going to look at, actually we're going to look at this all at the same time. So as you're going in and doing your regular dental exam, go ahead and open. You can have the patient open and say ah, and just kind of evaluate ah. Perfect. Evaluate the uvula. Is it enlarged? Is it reddened? Is it long? Does it just look like it obstructs that airway? Tonsils are another important area to look at. Does the patient have their tonsils? If so, are they a grade 1, 2, or 3? Which means how large are they? You'd be surprised, I have seen adults who have tonsils that almost touch in the middle of their airway. Again, a sign that they're probably not getting enough air when they're breathing at night, or they're getting a good collapse. Is there excess pharyngeal tissue? You want to look at that. Some people just have a lot of tissue back there. It doesn't even matter what their neck circumference is. Their soft palate extends far to the back of the throat, and then they've got just excess pharyngeal tissue. So all of that, all of those anatomical considerations can again tip you off as, okay, I'm sure this person is not breathing properly at night when all of that tissue loses tone and relaxes. The other thing we look at is occlusal wear. Is there an indication, go ahead and open, that this patient is clenching and grinding their teeth at night? That could be an indication that she's not breathing properly. The other thing is abfractions. She fortunately doesn't have any, but we do see a lot of patients who do have those abfractions that occur that we see in people who do clench and grind their teeth, and they get those concavities on the surfaces of, on the root surfaces of their teeth with that recession. So again, you can see how easy it is. It takes no time at all to just look. You can quickly see abfractions and occlusal wear as you're looking at the teeth and the integrity of the teeth. You can quickly ask the patient to say ah, assess the back of the airway for pharyngeal tissue, tonsils, uvula, any reddening. You can quickly look at the tongue, even as you're looking at the teeth, to see if it's scalloped or coated. And then have them, if you do suspect that there's some sleep disordered breathing, have them open and just assess tongue level and Mallampati. All of this, again, can be done within a few seconds while you're doing your regular dental exam. Putting this together with the health history, with some of the sleep questions, you can be a huge asset to your patient's health by being able to speak to them intelligently about what's going on possibly with their airway while they sleep, and then encouraging them to speak with their primary care physician or a sleep doctor about obtaining a sleep study in order to assess their quality of sleep. Simple steps that can be taken, and you could be saving your patient's life. If you have any questions, feel free to call Soundbridge Dental Sleep Apnea Therapy at 253-514-6076. I'm happy to help you with any questions you have on screening, or be a resource for you as far as where to refer patients if you do suspect that someone is suffering from obstructive sleep apnea. Thank you very much, and I hope you enjoy the rest of your day. This is a copy of the Stop Bang questionnaire, which can be easily added to your health history form. This is the questionnaire that I spoke about that is directly related to, or a direct screening tool for, obstructive sleep apnea. This is a copy of the Epworth Sleepiness Study, or Epworth Sleep Questionnaire. This is the screening tool that I spoke about that is not specific for obstructive sleep apnea, but is geared toward gauging a patient's daytime sleepiness. I just caution you with this questionnaire, even though again this is easily added to a health history, that this questionnaire is so subjective that it can change almost day to day, or even half day to half day. So despite the fact that a person may score low on this Epworth sleepiness score, does not necessarily mean that they do not have any type of sleep disruption. So I just caution you when using this study that you don't just hang your hat on the Epworth score, but that you look at other factors as well. This is the photo guide that I use when taking a person's Mallampati score. Again, you're going to have the patient just sit upright, open their mouth, and stick their tongue out. and evaluate how far into the back of the oral airway you can see with the tongue out. This is going to gauge tongue size as well as the amount of tissue in the back of the throat. Again, I just follow these pictures, and important to have the patient sitting up when taking this score. This is a photo guide you can use when evaluating a person's tongue size, and you're simply evaluating how far above the occlusal plane the tongue lies when the patient is sitting upright and opens their mouth. This is a photo guide to help you evaluate a person's tonsils. Everything from a tonsil grade of 0, which means that the person has had them removed, to a tonsillar grade of 4, which means their tonsils are large enough to be touching in the midline. This is great for 30s, 40s, 50s, and older. A lot of people have not had their tonsils out. It was not in vogue, at least when I was younger. So you probably will be evaluating tonsils when looking at an airway. Most people in that age group, in the sleep apnea type age group, will still have their tonsils.